Good afternoon. My name is Terri Woodard, and I'm an associate professor in the Department of Gynecologic Oncology and Reproductive Medicine at MD Anderson Cancer Center. And I hold a joint appointment at Baylor College of Medicine in the Division of Reproductive Endocrinology and Infertility. And it's my pleasure today to present to you some information and data on fertility and parenting issues for survivors and previvors. First of all, I'd like to mention that I do not have anything to disclose. The objectives for my talk today are to review reproductive considerations unique to this patient population, list the different options for fertility preservation and family building that are available to these patients, describe the process of in vitro fertilization or IVF, review the logistics of pre-implantation genetic testing or PGT, talk a little bit about some of the ethical concerns that are raised by the utilization of PGT, and explore some of the available outcomes data on the use of this technology. So first, I'd like to start out by talking a little bit about genetic mutations in adolescents and young adults with cancer. So we know that young adults with early cancers frequently associated with older people often have a higher percentage of inherited or germline mutations. And this rate is actually higher than what was previously thought. There was a study that was done at Memorial Sloan Kettering that looked at germline analyses on over 1,200 young adults aged between 18 to 39 that were diagnosed with cancer between the years of 2015 and 2019. And it was found that among these early onset patients, about 21% had germline mutations associated with cancer versus 13% in young adult patients. So this just highlights the fact that many of these young individuals have genetic mutations that can be passed down along to their offspring. And again, because these patients are younger, there are often fertility and family building issues that arise. So what are some of the concerns for these patients when it comes to fertility and future family building? And here I've listed several different conditions that we see frequently in our clinics that are referred to talk about genetic testing. So one is hereditary breast and ovarian cancer syndrome. And what are some of the unique concerns these patients face? Well, there is some question of whether these patients have diminished ovarian reserve. So maybe they suffer from some form of subfertility or infertility at a younger age than other patients. And these patients often need or do need eventually a risk-reducing salpingo-oophorectomy to prevent ovarian cancer. Lynch syndrome is another condition that we often see, and these patients have an increased risk of colorectal cancer, but they also have an increased risk for other cancers as well, including endometrial cancer. So prophylactic abdominal hysterectomy or laparoscopic hysterectomy and bilateral salpingo-oophorectomy are recommended. Leaf-Fermeni is another condition that we see, and these patients are prone to developing sarcomas, central nervous system tumors, breast cancer, but they also have gonadal germ cell tumors that may put their fertility at risk. And there are a number of other conditions that we often see as well, including FAP or familial adenomatous polyposis, multiple endocrine neoplasias types 1 and 2. But I think the key points to make on this slide are that if cancer develops, these patients may require treatment that can negatively impact fertility. So fertility preservation and conversations about it become of utmost importance. In addition, these patients may require prophylactic procedures that make reproduction impossible. So as I said before, women with HBOC may need their ovaries removed, similarly like patients who have Lynch syndrome. And then finally, the meat of this, which is what the meat of this talk is about, is that there is a risk of transmission of these deleterious mutations to offspring, and patients sometimes would like to take measures to prevent that. So here I'd like to just stress the importance of genetic counseling. So genetic counseling is particularly important for these patients because it accomplishes several things. One is that it can help identify families that are at risk for cancer. It allows patients to receive important education and counseling that can lower disease risk and presentation. It also is an opportunity to provide information about genetic testing and related procedures. So things like expanded carrier screening, where we might draw someone's blood and analyze it for over 200 different genes. And sometimes we'll often recommend specific gene panels looking at things that are related to their specific condition. And finally, it provides information about reproductive options, such as IVF with pre-implantation genetic testing, as well as prenatal testing. So I'd like to take a few minutes to talk about some scenarios where this testing and this counseling becomes very important, and what can happen when these gene mutations are passed along to offspring. So one condition is Fanconi anemia, which is associated with the BRCA1 and 2 genes. And this is a rare autosomal or X-chromosomal recessive disease that was first described by Guido Fanconi back in 1927. And it's characterized by congenital growth abnormalities, bone marrow abnormalities, and a predisposition to cancer. And the way this works is that the BRCA1 and 2 genes are genes in the Fanconi anemia pathway that are responsible for DNA repair. And when there are mutations, this DNA repair is altered and faulty. So if each parent has a mutation in this gene, there's a 25% chance of inheritance by offspring. So in this case, patients being counseled on this risk and being offered genetic testing, whether it's expanded carrier to screening to identify if they are carriers versus if they're thinking about becoming pregnant and doing pre-implantation genetic testing, it helps them have more control over their situation. Another example is Lynch syndrome, which is also known as hereditary non-polyposis colorectal cancer, or HNPCC. And this is an autosomal dominant inherited disorder that increases the risk of many cancers, but more importantly, or specifically, particularly gastrointestinal cancers. And again, this is a DNA repair gene, and this results in mutations that alter this repair, including MLH1, MSH2, MSH6, PMS2, or EpCAM genes. And the carrier frequency is about 1 in 279. And because this one is autosomal dominant, any offspring of a parent that have this mutation has a 50% chance of being affected. Another condition is constitutional mismatch repair deficiency syndrome, or CMMRD. And this one is pretty rare. There's only been about 200 cases of this reported in the literature. But it is also an autosomal recessive disorder that greatly increases the risk of developing many types of cancer in children and young adults. And similarly, you see mutations in PMS2, MLH1, MSH2, or MSH6 genes. And for this condition, because it's autosomal recessive, there's a 25% chance of having an affected offspring. So again, to summarize, it's important that people, A, know that they are at risk because they carry these mutations, and B, have the opportunity to talk about ways to prevent having these gene mutations being passed along. So there are multiple guidelines on fertility and family planning that exist out there, and I've listed a few of the more prevalent or more known about guidelines. So 2 guidelines that we often refer to for fertility preservation are the American Society of Clinical Oncology, or ASCO, guidelines on fertility preservation in cancer patients. And the American Society for Reproductive Medicine also has a committee opinion on fertility preservation and reproduction in patients facing gonatotoxic therapy. When it comes to specifically dealing with hereditary cancers and mutations, ASRM has a guideline on the use of pre-implantation genetic testing for monogenic defects or using PGT-M for adult onset conditions. And the NCCN also has guidelines that discuss genetic familial high-risk assessment for breast, ovarian, and pancreatic cancers. Of course, this list isn't comprehensive by any means, but again, shows that we are recognizing that having these discussions about fertility preservation as well as genetic testing are quite important and can make a tremendous difference in the lives of our patients. So let's take a few moments to talk about fertility preservation. And I refer to this as taking measures to protect the ability to have a biologic child. And often we see this in the context of prior to cancer treatment. So if someone learns they have a cancer, they're going to receive chemotherapy or surgery or radiation that's going to negatively impact their fertility. They can protect their fertility by freezing eggs, sperm, doing other measures, and I'm going to talk about those momentarily. The other area where we sometimes do fertility preservation is when people are going to need prophylactic surgery to remove reproductive organs. So in the instance of someone needing a bilateral salpingo-oophorectomy or removal of the ovaries, we might take the eggs first before removing the ovaries. And then of course, there's just elective fertility preservation. Someone might decide to do this because they're not ready to have a child at this time, and they're worried about trying to do so when they're significantly older. As people put off childbearing till their later reproductive years, more people are actually opting for this. So the different options for fertility preservation, and this is more in the context as it relates to having been diagnosed with cancer, are outlined here below. And the ones in red are kind of our standard of care go-to therapies that we recommend to try to preserve fertility. So for women, we utilize assisted reproductive technology, which includes oocyte cryopreservation, which is also known as egg freezing, and embryo cryopreservation, which is known as embryo freezing. For men, we can bank sperm. However, there are other methods of fertility preservation available, including ovarian and testicular tissue freezing. Ovarian tissue freezing is no longer considered to be experimental. However, testicular freezing is. Ovarian suppression, which I've included a slide about because there's often some question on what this is and how well it works. And then certainly there are other methods, such as if a patient is getting radiation to the pelvis, we can move the ovaries and the uterus out of the way. For gynecologic cancers, particularly those that are early or pre-cancers, we can be more conservative in our surgical approach. And gonadal shielding, which we don't see a lot of, but sometimes if the ovaries or testicles are in the radiation field, we can try to put shields to minimize the radiation exposure. So to talk a little bit about ovarian suppression, this refers to the use of GnRH agonists to try to suppress the ovary during chemotherapy. And the thought is that a quiet ovary is more resistant to the effects of chemotherapy than one that is actively cycling. I will say that the use of these drugs for this purpose is considered to be experimental, and the data that exists out there is quite variable as to whether we think this works or not. My personal opinion is if this is the only thing that we can do, it is or could be potentially helpful, and in general, the potential benefit usually outweighs the risks. The other thing is that this is one form of fertility preservation that we can sometimes get covered because we can code it as menstrual suppression instead of fertility preservation. Because as you know, most people do not have coverage for fertility services. Again, I will say that this method of fertility preservation is somewhat controversial. However, there was one study that looked specifically at women with triple negative breast cancer and found that it seemed to work. They found that pregnancy occurred in more women in the goserelin group than in those that received just chemotherapy without it, and that was 21 versus 11%. And they also found that the rate of premature ovarian insufficiency was 14.1% in the group that received the agonist versus 30.9% in the control group. A total of 37 or 10.3% of patients had at least one post-treatment pregnancy in the agonist group versus 20 or 5.5% in the control group. Now, people who criticize the study will say, well, this study was not designed to answer this question, and that is indeed the case. This study was not designed to answer the question of pregnancy after ovarian suppression, but it does provide some reassurance and some basis for prescribing ovarian suppression during chemotherapy for women with triple-negative breast cancer. So what are the different family building options for our patients? And as you can see here, there is a great range of opportunities that are available depending on what the patient is comfortable with. So some will just naturally conceive. Others will use assisted conception. So they might use things such as ovulation induction agents, which can be oral, or they can be stronger injectable medications. And this can be combined with intrauterine inseminations or simple intercourse. We talked a little bit about assisted reproductive technology, which is essentially IVF, and I'm going to go into more depth about that shortly. For patients who for some reason don't have eggs or sperm that are viable, or maybe they've had premature ovarian failure because of cancer treatment, we can utilize third-party reproduction, which includes the use of donor eggs, donor sperm, donor embryos. And for women who may not have a uterus or may just not be healthy enough to carry a pregnancy, or it would be deemed too high risk, we can use gestational carriers or other women who agree to carry their pregnancy for them. And finally, people have the option of adoption, which is a great option for many patients. However, I do want to note that sometimes adoption can be challenging for survivors of cancer because some agencies see it as too risky and do not allow those patients to pass kind of the initial screen. So asking an adoption agency whether a cancer diagnosis will disqualify them early on is a very important question for patients to ask. So let's talk a little bit more about genetic testing for future offspring. So the two questions we are asking is, what can we do if we want to know the mutation status of present or future offspring, and when do we want to know this information? So there are really two types of genetic testing that are available. So one is for an offspring that has not yet been conceived, and the other is for offspring that has been conceived. So first, I'm looking at for offspring that have already been conceived. So the patient has already been pregnant. There is the availability of prenatal genetic testing. So that has two types, screening and diagnostic. So screening tells us the chances of aneuploidy or having abnormal genetics in terms of number of chromosomes and sex chromosomes. And it can also give us information about whether this particular fetus is at risk for a few other disorders such as neural tube defects. And the way we do this is by doing what's something called a first screen, which is a blood test and ultrasound that is performed between 10 and 13 weeks of pregnancy. And then later on during the second trimester, we offer the quad screen plus an ultrasound, which is done at 15 to 22 weeks. Now, the other type of prenatal genetic testing is diagnostic, and this is the testing that can tell us if a fetus is affected by a certain disorder. And the two types of testing that can be done is CVS or chorionic villus sampling, which is done at 10 to 13 weeks. And basically what is happening is that we are either abdominally or transcervically biopsying that early placenta. The other option is to do what's called an amniocentesis. So that's sticking a needle into the belly to collect some of the amniotic fluid surrounding the baby. And this is done between 15 and 20 weeks. The problem with prenatal genetic testing is that the patient is already pregnant. So if we find an abnormality, it really has some implications and has patients facing some hard decisions on whether they would want to continue the pregnancy or not. So the screening that is done this way is often done better earlier in the first trimester or late first trimester than waiting. When we talk about testing for a future offspring that has not been conceived yet, this is where we talk about pre-implantation genetic testing. So this is testing an embryo that we get after doing the IVF process, and we test it prior to transplanting it back into the uterus. And there are kind of like three flavors of pre-implantation genetic testing. So there's PGT-A, PGT-M, and PGT-SR, which I will talk about shortly. So what is PGT in general? PGT, or pre-implantation genetic testing, is testing an embryo for abnormal chromosomes or genes before they are actually transferred back to the uterus. And as I said before, we have three types. So PGT-A, which was formerly known as pre-implantation genetic screening, or PGS, is testing an embryo for whole chromosome abnormalities. So it can pick up things like Down syndrome or trisomy 13, Turner syndrome. Then there's PGT-M, which is also formally known as pre-implantation genetic diagnosis. And this is testing an embryo for a specific gene. So for instance, if a woman is a carrier of a BRCA mutation and she wants to test her embryo for that mutation, this is the type of testing we would use. And then finally, there's PGT-SR, which is testing an embryo for chromosome rearrangements. So I'd like to just share a little brief history about PGT. So it actually goes back quite some time, but not in humans, but in rabbits. And in 1968, someone did the first trophectoderm biopsy in rabbits to predict the sex of offspring. And it was not until 1990 that we had the first live birth from blastomere biopsy. So that's one of the early cells in an embryo to perform PGD for adrenoleukodystrophy. In 1992, we had the first live birth from blastomere biopsy for a specific mutation associated with cystic fibrosis. And then in 2005, we had the first birth after trophectoderm biopsy and blastocyst transfer. So the difference between testing blastomeres, which are actually cells from the embryo, versus the trophectoderm, which are cells from the developing placenta, is that we are much less likely to damage the embryo if we do a trophectoderm biopsy than the blastomere biopsy. So what steps have to happen before we can do a PGT-M cycle? So first, patients are referred to genetics for a consultation, and this may be within a hospital or a practice, or it could actually be with the PGT company itself. Then a case review is done by the testing laboratory, and then they start the testing preparation for the PGT-M. So actually what happens is that we often have to get samples from the patient so that we can identify the specific mutation, and probes have to be built. And sometimes it can take up to several months to build the probes for the specific gene mutation that we're looking for. Once that has been done, the patient goes through an IVF cycle, and I'll talk about what that entails shortly. And then the resulting embryos that are formed are biopsied, and those biopsies and the embryos are frozen. At that point, the pre-implantation genetic testing is performed, and we get a result back in several weeks that show us whether these particular embryos are affected by the mutation or not. And once we know that, we can pick the embryos that do not have the mutation and do what's called an embryo transfer to get the patient pregnant. So this whole process can easily take several months, depending on how long it takes to build the probe, how ready the patient is to go through IVF, and so forth. So this is a little slide that just describes the process of IVF. And I like to describe this to my patients as your ovary doing what it normally does each month to the 10th power. So normally in a menstrual cycle, your ovary is going to recruit one follicle that grows and releases a mature egg. But in this scenario, we're giving strong fertility drugs called gonadotropins that women inject on a nightly basis for about 10 days in most cases. And during those 10 days, she comes in for ultrasound and blood work to talk about what we have to do with her dosing. And we get to the point of around day 10 where the eggs are mature and we do what's called a transvaginal oocyte retrieval. And we do this under ultrasound guidance, and we gather the eggs. And if we want to create embryos, we fertilize the eggs with sperm to create the embryos and grow them out over several days in our lab. So this is an example of when we're doing an egg retrieval, what the ovary looks like. So we basically suck the fluid out of these follicles, and then in that fluid, we have the eggs. We fertilize the eggs with the sperm, and that creates a pronuclear embryo, which then turns into a cleavage stage embryo and then a blastocyst. And this is actually what is biopsied for the PGT testing. And this is a picture of an embryo actually getting biopsied. And then once we send those cells for testing, we get a report and we do what's called a transfer. In the interest of time, I'm going to skip over some of the biopsy techniques, as well as some of our screening methods, and talk a little bit more about how well this technology works. And the best data we have comes from the BRCA and PGD literature. So the first report of a live birth following PGD for a BRCA mutation was in 2008. And just to note, it does not appear to be any increased risk for breast cancer patients and those that are BRCA mutation carriers. But they looked at a number of IVF cycles for these patients, and out of 145 PGD cycles, 720 embryos were tested, and about 40.8% were actually BRCA negative. And in 87 fresh cycles, when 1 to 2 embryos were transferred, there were 34 clinical pregnancies. So, we know that this works and we have reasonable pregnancy outcomes. There is another paper that looks at outcomes for PGT patients as a whole, so not just specifically looking at women with BRCA mutations. And this came out of a private IVF clinic in Canada. And they had 73 PGT cases. So these included PGT-M and PGT-SR. And of the 45 PGT-M patients, 64.4% had at least one euploid unaffected embryo. And the cumulative pregnancy rates for patients who had embryo transfers in this group was 89.7%, with an ongoing pregnancy or delivery rate of 49%. So again, we know this technology works. And this is just a little table that talks about the different conditions that patients had and the pregnancy rates that ensued. Here, I'd like to talk a little bit about the ethical concerns associated with pre-implantation genetic testing. So some people use it for sex selection, which historically has been a little controversial, but that has been changing. Some people have feelings about the indication, so whether the disease that we're testing for is fatal versus non-fatal. We have patients that come in for testing because they have another child that has something like sickle cell and needs a bone marrow transplant. So they call these savior siblings, and people have strong feelings on whether that should be allowed. And I will say that patients themselves struggle with these decisions. So many patients agree that PGD should be offered, but we found that only a minority would actually consider this for themselves, which I think highlights the importance of counseling and thinking through the decision. And I do want to refer to one of the guidelines that I mentioned earlier by the ASRM. We do feel like this is ethically justified. They specifically say in their committee opinion that PGD for adult onset conditions is ethically justified when the condition is serious and no safe, effective interventions are available. It is ethically allowed for conditions of lesser severity or penetrance. The committee strongly recommends that an experienced genetic counselor play a major role in counseling patients considering such procedures. So in conclusion, hopefully I have discussed satisfactorily that individual risks individuals at risk for hereditary cancer have unique reproductive concerns, that fertility preservation is an option for increasing the chance of biological parenthood when fertility is threatened by prophylactic procedures or chemotherapy or cancer treatment, and that PGT, and specifically PGT-M, is an acceptable method to prevent transmission of mutations to offspring, but requires in-depth genetic counseling and support. Thank you.